I would treat this chapter in much the same way as the chapter on depression, with supplemental information providing through hyperlinks. Anxiety may be one of the most common mental health symptoms in adolescent clients. It's going to be important for you to pay attention to the severity of anxiety as you work to determine what is developmentally appropriate and what is pathological. As you work towards formulating a diagnosis of anxiety, remember to pay attention to the client's medical history, any substance use issues, and any history of anxiety disorders in the family. One common occurrence in the realm of anxiety disorders is the panic attack. Whenever panic attacks occur on a regular basis, clients tend to worry about additional attacks and may even begin to change their behaviors in an effort to avoid future attacks. As you all know, many who experience panic attacks describe them as feeling as if you're having a heart attack. Another common expression is that individuals feel like they are going crazy whenever they experience a panic attack. Some believe that panic attacks are only a biological misfiring, whereas others agree that biology plays a role, but they also believe that environment contributes. This hyperlink will take you to a page that describes the neurochemistry of panic. In addition to panic disorder, teens may experience phobic fear of certain situations or objects. If this is the case for one of your clients, I'd encourage you to review the behavioral shaping techniques from the Brems text, as behavior modification is often indicated when working with phobias. The hyperlink on this page will take you to an article about social anxiety disorder in children and adolescents. Social anxiety is described in the DSM-5 as a marked or intense fear of social situations in which the individual may be scrutinized by others. This particular disorder is likely to begin during adolescence, as teens move from being emotionally invested in their families towards developing meaningful peer relationships. Prior to the DSM-5, clinicians would diagnose agoraphobia as existing with panic disorder or without panic disorder. Now, agoraphobia is listed separately. This differs from social anxiety in that the client has significant fears about certain situations, such as leaving the house, using public transportation, or being outside of the home alone. In my work at Sound Mental Health, generalized anxiety disorder was fairly common. As with depression, generalized anxiety is more common in females, and clients tend to become overwhelmed by what we might consider minor worries. Once again, I believe that using cognitive or behavioral approaches will work well for you when you have these clients. One of the most substantial changes to the new DSM is the new chapter on obsessive compulsive and related disorders. You have a couple of hyperlinks on this page. Be sure to check out the information here. OCD usually begins in late adolescence, although it can occur earlier. Here are some criteria from the new DSM to keep in mind. Treating anxiety disorders most often includes a combination of medication and cognitive behavior therapy. Whenever your client is under a physician's care for medication, please remember that anti-anxiety drugs need to be closely monitored. Okay, that's it for this chapter. I know I've hyperlinked a lot of documents for you. Please don't worry about printing these out for class. I'll provide everything we need, except for a copy of your PowerPoints from the module if you'd like that.